my name is Karen, and today I will be talking to you about using clinical judgment and practice excellence to impact outcomes. Clinical judgment is an aspect that all of us use as nurses. It's continually evolving. The clinical judgment I had as a new grad is different than I have now, and the clinical judgment I have now is different than what I'll have in 10 years. Regardless of where you are on that spectrum, you have clinical judgment, and in many cases, it will help you perform life-saving interventions. As you progress in your career, you'll face situations that make an impact on you and the way that you grow as a nurse. I still remember the first time I noticed that a patient's potassium needed to be replaced because it was low and they were on Lasix. I got the order from the doctor and thought I was amazing for recognizing this cue from my patient. That small cue recognition and being able to successfully identify it motivated me to and encouraged me to continue my learning and grow my expertise as a nurse. Now I want to tell you about a big specific example where I used clinical judgment and it made an impact on me. My patient, John. John is a gentleman in his 70s who comes to the hospital with a history of aortic stenosis, hypertension, sleep apnea, and coronary artery disease. He's here today to get a TAVR. This is a procedure that's minimally invasive where they go in through the femoral artery rather than a sternotomy to give a patient a valve repair. 5 years ago, these patients were admitted to the ICU and kept in the hospital for days. Now they go to the step-down telemetry unit and get discharged the next day. Even though the turnaround is faster, the risks for complications are so high, and noticing these cues in that short period of time are crucial to the patient's safety. Cue recognition for John started in my chart review. I got a report at the beginning of my shift. I was told that the procedure went on without complications. John had been vitally stable, and he had 4 hours of bed rest left. Now, patients with this procedure have bilateral groin sites. John had a femoral and an arterial sheath in his right groin that were small. In his left groin, this is where they did the TAVR procedure, he had a 20 French arterial sheath. Now, my experience tells me if John's going to have the complication of bleeding, it will probably happen on that left side. So the novice nurse gives me a report. She says, John's groin has been bleeding just a little bit, but I put a new dressing on it. So if you notice any shadowing or bleeding from the dressing, that's all new since the start of your shift. We shifted the remainder of our report to the bedside. His right groin looked perfect, soft, no hematoma, no bleeding. The left groin, however, had new shadowing under the dressing. The novice nurse said, it's fine, it's just a little bit, but I knew that the bleeding that was happening was more than could be stopped on its own. So I went ahead and positioned the bed for me to hold pressure on John's groin. You keep pressure for 20 minutes at this point. I was able to stop the stop the bleeding. Normally this action can be pretty painful for clients, but John said he tolerated it fine and his vitals remained stable through the whole time. So, brief recap, the cues I knew from report for John were that he was fine up until this point, all within defined limits. My assessment led me to recognize that he was bleeding. My immediate priority was to hold pressure, and the outcome was him tolerating the intervention and the bleeding stopping. After my intervention, I told the cardiology team. They came and saw him. Nothing else was out of the ordinary, so they said, just let your nurse know if you have any pain at your groin site. In the setting of any bleeding, the standard 6-hour bed rest for a patient with a groin site starts over. So at this point, John's bed rest is going to last until at least 2 a.m. I finished my complete assessment, and I educated him on the monitoring I'd have to be doing overnight. My own assessment on John provided more cues for my clinical judgment. So John was alert and oriented ×4. He's on room air. Lung sounds clear, no shortness of breath. He's in sinus rhythm with a heart rate in the 90s, and his pressures look great. They're 110s over 70s. He denies any pain except when I palpate his groin, but when I asked him a little bit more about this, he said, you know what, I'm actually having 5 out of 10 back pain. He said, I have chronic back pain. You don't need to do anything for me. Just don't worry about me. Now, the previous nurse told me John had absolutely no pain. So this is different. His distal pulses are strong. He's pretty frustrated over having to lay flat for 6 more hours, but he keeps assuring me I'm fine, don't worry about me. I told John that the orders for a TAVR procedure require every 2-hour neurological assessments. Also, at this point post-procedure, we'll have to do vitals and groin checks every 4 hours. John expressed more annoyance over having to be woken up all night long and said, I'm fine, don't worry, I don't want to be a bother. As a novice nurse, I probably would have done exactly as the order said and only done the 4-hour vitals and groin checks and every 2-hour neuro assessments. As an experienced nurse, I had enough information to think there might be something else going on. So the cues I recognized as priority: John's blood pressure is normal, but John has a history of hypertension. He's been NPO all day. He didn't take his antihypertensives this morning. So for John, this blood pressure that looks normal is actually probably pretty low compared to his baseline. I also noticed while I'm looking through the chart, John's gotten increasingly tachycardic throughout the day. His heart rate is still considered normal, but in the morning he was in the 70s and now he's in the 90s. Both of these are probably due to hypovolemia since John hasn't eaten or drank anything all day, and he probably lost a little bit of blood during the procedure. Next, John was dismissive about discomfort. He had a seemingly high pain tolerance. He said he had 5 out of 10 pain, but he didn't want me to do anything about it. He also didn't tell the previous nurse about the pain. So for now, he's dismissive about my monitoring. He doesn't want me to worry about his pain. His vital signs are different from his baseline, and he's already had 1 post-procedure complication. My cues are complete. I'm on to analyzing them, and my experience tells me John's probably at a risk for some kind of other complication, and I want to keep a really close eye on him. My hypothesis is that he might be hypovolemic, and my solution is to monitor John more frequently until he gets off of bed rest. So I leave a blood pressure cuff on and cycle it to check blood pressures every 30 minutes, and my plan is to check John's groin every 30 minutes as well. I also try to reinforce the need for John to call me if he has any pain in his groin. Pain at that site may indicate bleeding and increased pressure to the groin that could be the sign of a hematoma. After an hour of no signs of change with him, everything's normal. I decrease my monitoring to every hour, and at 10 o'clock I go in to see how he's doing. When I look at the monitor, the blood pressure that was taken just a few minutes ago reads 80s over 50s. I restart the cuff and take a look at John. He seems to be in more distress and lets me know he's in a lot of pain now. My immediate response is to check his left groin, and right away I see his previously flat and soft site has a softball-sized lump with significant bruising around the dressing. I apologize to John and let him know I'm about to hold pressure and it's going to hurt a lot more than it did before. Another nurse hears me from outside the room, comes to see if I need help. I asked her to call the team, the cardiology team, let them know about his blood pressure. He's more tachycardic, and I'm holding pressure over a large hematoma. I asked her to get some pain medicine also and let the charge nurse know what's going on. John's response to me holding pressure was not relaxed like it was last time. He's in 10 out of 10 pain. My charge nurse comes into the room, and now John's most recent blood pressure is reading 60s over 40s. He has a sudden drop in heart rate. He's bradycardic in the 40s. He's restless, he's tired, and he is in a lot of pain. My charge nurse immediately gets another nurse to grab atropine from the Pyxis. She puts the bed in Trendelenburg position so John's head is down. The doctors come into the room. They kind of get him to be a little bit more oriented. They tell me, reduce my pressure. Now his next blood pressure is 80s over 50s. They say, let's hold off on the atropine and pain medicine. Go ahead and check and see what his neurological status is. John's vitals slowly start to improve. His mentation is better. And after holding pressure on his groin for 20 minutes, his blood pressure comes back up to 90s over 60s. His heart rate comes back to the 90s. The bleed that John had at that point was minor. We checked his hemoglobin. It was an insignificant drop. He had no further complications overnight, and he actually ended up going home the next day. I like to talk about this situation because it's such a great example of how different levels of expertise produce different responses. But for each nurse, the novice, the competent nurse, and the expert nurse, we all use clinical judgment the same. The cues were less obvious for me than they were for the novice nurse, so I picked up on things that she didn't notice. When John's blood pressure was dropping, I just thought he was hypovolemic. When his heart rate started tanking too, I just panicked. My charge nurse, she knew instantly that he was having a vasovagal response. She knew he needed atropine and his head needed to be put down in Trendelenburg position. None of us did the wrong thing. According to Benner's novice to expert model theory, each nurse functions at the best of their ability based on their experience. That experience brings about different actions because we know more, but the clinical judgment is always the same. Now I want to talk about practice excellence. We all have unique experiences that bring us to nursing and take us through our journey as nurses. In my pursuit of nursing, I decided I wanted to become a nursing assistant so I could gain comfort with patients, and I started that in a nursing home. I saw a huge gap between what nurses were supposed to be doing and what they were doing. I still saw some really excellent nurses though. Then I went and worked in an ICU. I was blown away by the integrity that nurses had and how well they took care of their patients. In this situation though, I still found the nurses that didn't take great care of their patients. And in both of these examples, I recognized those nurses who were taking really good care of their patients were practicing nursing excellence. They were the kind of nurses that I would want taking care of my loved ones, and I decided I'm going to be the kind of nurse who other people want to take care of their loved ones. My goal to pursue excellence in nursing translates into me being committed to upholding evidence-based practice, maintaining my education and knowledge, advocating for my patients, and providing quality care. Part of doing these things is challenging the status quo. It's important to me to pursue excellence, and a way that I have sought out to do that is by joining the unit council in my unit. We talk about ways to do things better, find new interventions and recognize opportunities for us to drive healthcare forward, to challenge current ideas and improve our patients' outcomes. Next, I practice having the courage to do the right thing. Recently on my unit, we had a really difficult patient who people didn't want to take care of. He had been verbally abusive. He had a lot of mental illnesses. I got to take care of him one night, and I decided I'm not going to let any of these past experiences bias me against him. I'm going to go in there and care about him as a person. I ended up getting him new orders for Imodium, pain meds, and sleep medication that night. He woke up the next day and said, "This is the best night I've had since I've been in the hospital." My goal to take care of this patient was to help him, and my ability to do it without bias was still difficult. He was verbally abusive most of the night, but my pursuit of excellence allowed me to do the right thing, even when it wasn't easy. Research shows that nurses who have the courage to maintain morality in difficult situations actually feel empowered by them. Next, pursuing excellence means collaborating to achieve the best outcomes for patients. Now, when I think of people I want to collaborate, we all think of our healthcare team, doctors, therapists, everybody involved. But for me, the biggest collaborator that I want to work with is the patient. And sometimes that's really hard. We've all had the people who are very particular, and sometimes those particular preferences they have actually gotten them to the negative health outcomes that have brought them to the hospital. But it's important that we are using therapeutic communication so we can be good stewards to help our patients find solutions that honor their preferences and also help achieve better health outcomes. Since the beginning of nursing, the profession has consistently grown and expanded, and now has a focus on, being a notable profession. And part of that has been increasing the amount of bachelor-prepared nurses that are working in our field. When I first started, I had an associate's degree, and I said, what's so different about a bachelor's degree? But I said, what the heck? Why don't I find out? And getting my bachelor's taught me a lot. It taught me that there's still so much that I want to learn. And that didn't stop after I got my degree. It's just continued as I've been a bedside nurse and cared for patients. Lifelong learning goals for me would be getting certifications in the areas that I work in. I would love to get my cardiac care certification. Someday the ultimate goal would be to become a clinical nurse educator and be able to teach other people and instill that love of learning for them. Getting your bachelor's degree and pursuing that lifelong learning is at the cornerstone of being a nurse and pursuing excellence as nurses. And Using the clinical judgment model is a big way of how we do that.